Now tonight our guest speaker is Hilda High, or should I say Dr. Hilda High, should be very formal. Dr. Hilda High is a genetic oncologist. She works with the Sydney Cancer Genetics and the Northern Haematology and Oncology Group. This is the one we call NHOG for obvious reasons. And that group provides comprehensive cancer care for patients and their families. She specialises in the assessment of inherited cancer risk, something we're probably all very interested in, genetic counselling and testing, as well as cancer risk management. Dr. High completed her medical degree at Sydney University with honours and completed her Masters of Community Health, for which she won the Master of Community Health Prize through the University of New South Wales. She is aware of the emotional issues that can arise when discussing family cancer histories, as well as sometimes complicated dynamics of a modern family. Hilda has a keen interest in research and has presented her work at national and international conferences and has published in key international journals. Hilda is a member of the Cancer Institute and EVQ, is that the way you say it? The EVQ group, working with other national experts to provide standardised Australian guidelines for the testing and management of inherited disorders associated with cancer. Committed to increasing patient access to cancer genetic specialists, Hilda conducts telehealth consults to regional, rural and remote areas. Would you please welcome Dr. Hilda High.
What I wanted to run through today is, or this evening I should say, is a little bit about prostate cancer and what we know about the inherited risk. But I should be very frank up front, there's a lot we don't know when it comes to prostate cancer running in families. So what I'd like to do is talk a little bit about what cancer actually is and why it sometimes runs in families or seems to run in families. And that's where the family history or pedigree comes in. I'll then talk about some of the genes that we know that are involved and how we go about doing tests for those. One of the things I find I often get asked is, well, I don't need to be counselled. So I will talk a little bit about informed consent and then some of the research that's going on at the moment. So this is the analogy that I use for cancer. The idea that an ordinary healthy cell knows what the rules are and follows it. So to me, that's the adult. So the ordinary everyday prostate cell knows what to do, how to behave, and does that. But you can have pre-cancer cells. And these pre-cancer cells I think of as the adolescents. They've, I don't know, got a funny haircut, tattoo, a piercing, but hopefully like most of the kids out there, they don't all turn out bad. From a cell point of view, these changes are what are called somatic. That simply means that they've only occurred in that prostate cell. So you can't pass that on to the next generation. Cancer cells, on the other hand, they're the delinquents. They don't follow the rules. They grow when they shouldn't, don't die when they should, and some of them move to other places and cause problems there. We've got our immune force, and that's the immune system, I should say, and that's our police force. Unfortunately, like our ordinary police force, it's not perfect. And for some of the treatments that you may know about within prostate cancer, some of those do actively use the immune system. Another way to think about genes is to think about books in a library. So we've got 20,000 genes sitting within the DNA, and they're on chromosomes. Each time a cell makes a copy of itself, it has to copy out the entire library. And every cell making a copy of itself makes about 120,000 mistakes. Fortunately, we've got some pretty strong spell checkers, and they fix those mistakes 99.9% of the time, but that still leaves quite a lot of mistakes sneaking through. And these mistakes can be tiny, a tiny little spelling error, a one-letter change. They can also be little chunks missing, and if enough of those build up, that's what cancer is. It's like vandalising the library, ripping out pages, just mucking everything up. Importantly though, one change, one mutation, isn't enough to create a cancer. And one of the reasons that we see more cancer at an older age is simply because it takes that long for these random mistakes to build up. So why does cancer run in families? The one that most people think about is a fault in a gene being passed down generation after generation. But that's actually really very rare. Sometimes it's because of gene-gene interactions. These are the modifier genes, and they're the ones that are turning up in the newspapers and the non-scientific journals, but they're turning up a lot in the scientific journals as well. And these are the things where there may be somebody you know who drank, smoked, did everything apparently wrong and still lived to be 100. They've probably got a lot of the good modifier genes. But some families, they've got genes that aren't doing their job properly, and so we see more cancer than we would expect. Gene-environment interactions, I suppose the most obvious example of that is that if you've got blonde hair, blue eyes and fair skin and live in Australia, you're going to have more melanoma than somebody else who's got darker hair, darker skin. Diet and lifestyle, and I'll come back to that a little bit, it is actually really important, and there are studies showing that even doing things now can alter genes and prevent cancer. But most of it really is just because we're aging, and that aging process allows us to collect more of those mistakes. So how do we know when there is a mistake in a gene being passed down in the family? Some syndromes actually have a look, a phenotype, freckles on the inside of the mouth or a very large head or something that gives it away. There's very little of that associated with prostate cancer. Really what we tend to rely on is a family history. And that's not just the history of prostate cancer, but other cancers in that family. It may be some rarer tumours, and the age at which people are affected is really important. If cancer's common as you get older, they now say 2 out of 3 people will get a cancer, then it's really important to know how old were the people in the family when that happened. And we do have a sneaky test that we can do in some situations, and I'll come back to this. We can actually test a tumour in Lynch syndrome, and it was one of the Australian researchers at North Shore where I work recently published a paper about how we can even test a prostate cancer to demonstrate the presence of Lynch syndrome. We're designed to look for patterns, and I love this. Sometimes, though, when you look and see a pattern, it isn't actually telling you what you think it is. So the shrinking underwear is not necessarily positive proof of global warming. Instead, what we try and do is use something like a family history. And this is a very common situation for me when I was working as a medical oncologist and now, that a mum turns up with her daughter. And it's the daughter who's worried or the mum who's worried about the daughter. And in this case, while taking a family history, it turns out that Dad had prostate cancer at 66. Most people think that you inherit your genes through your mum, is what I seem to see. Particularly breast cancer genes seem to come from mums and prostate cancer genes from dads. Obviously that's not true. You get half your genes from your mum, half from your dad, and any of those may potentially carry a mistake. So it's really important to think about how common a cancer is and then put it in the context of the family history. So these are figures that you probably know. Prostate cancer happens at an average age of about 67, and if you're 65, you've got about a 6% chance of having prostate cancer. So having a dad who's had prostate cancer at an older age doesn't necessarily put you at any increased risk. In fact, if Dad has good genes and lives to be 85, then he's got a 1 in 4 chance, a 25% chance of having prostate cancer. So again, those are good genes, not necessarily a fault in a gene causing that. So in this case, often the GP will take the more detailed family history, and here it turns out that Dad's sister had a breast cancer and his mum had a breast cancer. His aunt also had what seemed to have been a cervical cancer, and he's got a nephew who had prostate cancer at what is actually a reasonably young age. Part of my job is to then confirm the pathology. What sort of cancer really was it? And in this case, it turned out that it wasn't cervical cancer, which you may well be aware of is caused by a virus, but ovarian cancer. An ovarian cancer at a young age. we would now offer a test to all women under the age of 70 who had ovarian cancer of a particular type. So if there's ovarian cancer in the family, that's a bit of a red flag to somebody such as myself. So what are we thinking about here? Well, sometimes when cancer runs in a family, familial prostate cancer, when there's more than one person or young prostate cancer, it's actually about 10%. So 90% of prostate cancer doesn't run in families. The little graph on the other side is looking at what genes do we know about, the high-risk genes. That's that little orangey triangle there. And those are the very uncommon things where we can put our finger on an actual gene. I'll come back to what a GWAS and a SNP is, but as you can see, 3/4, even of when we see the prostate cancer in families, we still don't know what that's all about. The genes that I'll talk about next, BRCA1 and BRCA2, were made quite famous last year by Angelina Jolie, and they are, in terms of prostate cancer, probably the biggest risk of cancer following a familial pattern. But it explains about 2%. So if a man had prostate cancer under 55, he's got a 2% chance of carrying a mutation, 98% chance he won't. Within our system, and I'll come back to this, we don't tend to test unless we're pretty sure that there's a 10% chance. So there needs to be an awful lot of prostate cancer in a family before we start testing. But it's an important gene to know about. And BRCA2, as you can see, is the one that really increases prostate cancer risk from that average of about 6% up to about 15% over a lifetime. BRCA1 increases the risk as well, but not as much. But in fact, it's more about the other family members, the sisters, the mothers, and the daughters that we worry about with these genes, because these are the population risks. And you can see that the risk of breast cancer jumps up quite substantially. The risk for men also goes up. We don't do anything special. You don't need to have mammograms. You just need to be very aware. In fact, I said that to a couple, actually, that you just need to be breast aware. And his wife said, he's very breast aware. And I don't think that's what I meant. But with the women, there are some very important things we can do if we know that that is the increased in the risk. The other thing is the ovarian cancer, and I brought that up before. It's very important because about 10% of ovarian cancer is caused by mistakes in these genes. So what do we do? For the prostate cancer, there's no specific things that we do to reduce risk. For the breast, there is. You can have the risk-reducing surgery, similar to Angelina, or you can have increased screening that starts at age 30 and is done every year. Some women will even use a tablet that's used to treat breast cancer to help reduce their risk by about 1/3. For the ovaries, the screening doesn't work. We need to actually remove the tube and the ovary, and we now know that in most cases it's actually the tube where these cancers start. And we need to do that at around about age 35-40 for the BRCA1 mutation carriers and around about 45 for the BRCA2 mutation carriers. And that's sometimes when women are still trying to complete families. So again, important information. One of the things about removing the tube in the ovary is that fairly obviously we reduce the risk of ovarian cancer, but it also halves the risk of breast cancer if that's done before the natural menopause. And in a woman who's not had a breast cancer, we can use hormonal replacement therapy. Male menopause? Female menopause. I think the thing about the female menopause is that it can be difficult, but that hormonal replacement therapy can be used in those younger women to protect bones and other things. So here we go again, but a different family history this time. Same situation, this time the mother's got colon cancer and she's again worried about her daughter. Taking the history on the father's side, it turns out that his sister had a colon cancer, and again that possible cervical cancer at 45, and in this case it was his father who had a colon cancer. Now, one colon cancer in the 60s, that's average. Nothing that you need to do special. You simply do the fecal occult blood testing from age 50 every year. Once there's 2 people in the family, this man with prostate cancer and his brother, they could be considering having colonoscopies every 5 years, probably again from age 50. But the fecal occult blood testing may be all they need. Again, my job to find out what was this really, trace down that pathology, and in this case it was a uterine cancer. And the reason that the daughter was there with her mum was that she just found out on Facebook that her cousin had had colon cancer at 30. So a very different family history. And in this situation, we're looking at something called Lynch syndrome. And I mentioned before that we've got a staining test we can do for this. It's a stain that they apply to thin slices of the cancer. And what we do is we stain it 4 times, 1 for each of the 4 genes that are associated with Lynch syndrome, and hopefully it binds and we get a positive stain. If not, it could be a sign that these genes have been damaged inside that cell, and that's often because one of them was inherited as a faulty gene and the other one from mum or from dad was damaged later. These genes are referred to as the mismatch repair genes, and their job is to look for and fix those mistakes in the DNA. So when we do the staining test, if the gene isn't working, the protein isn't made, and the staining will be negative. And this is the study that I was saying that we now know we can perform on a prostate cancer. We wouldn't normally do it that way, but sometimes we don't have access to the uterine cancer or the bowel cancers. This is what it looks like, and I'm sure even though there may or may not be a pathologist among us, you can tell that they look quite different. The one on this side is showing the dark staining. This is the cancer, this area here, and on this side you can see it hasn't stained. You know that the stain's worked though, because these little tiny black dark flecks, these are white cells, and they're staining normally because although one copy's been damaged, the other copy's working. So what actually is Lynch syndrome and why do we care? Well, it increases colon cancer risk, probably up to about 40%. We used to say 80% over a lifetime, but we now know that it's less than that when you actually don't select based on cancers in the family, which is what we used to do. We used to actually look at cancers, families with lots of cancers. For women, it's slightly less. But for women, there's also that risk of uterine cancer and, again, ovarian cancer. There are some other cancers associated with these syndromes. We don't tend to screen for those ones. They're relatively rare, but they can pop up in the family tree and give us some clues. This used to have lots of horrible names, hereditary non-polyposis colon cancer and other things, and we will call it all just Lynch syndrome. And in fact, this is Bowel Cancer Month, and last Saturday was actually Lynch Syndrome Day for those of you that might have heard about it. Again, why do we care? Well, this is something that you can do a lot about. We need to start early because the cancers start early. Turn off your spells checker and the mistakes build up faster. So we actually start screening at age 25. It's just a colonoscopy, and the idea is that you'll get rid of a polyp before it has a chance to become a cancer. As I already mentioned, screening doesn't work for the ovarian cancer, and it hasn't been shown to be useful in looking for the uterine cancers. So again, for women in the family, we'd recommend that the tubes, ovaries and the uterus as well in this case are removed around about age 40. Some things are obvious, or at least you'd hope that they were obvious. One of the things that's probably the most important thing you can do, apart from if you are one of those families finding the gene and then working out who in the family needs the extra screening, is to actually follow a healthy diet and a healthy lifestyle. It's very easy to say standing here at 7 o'clock at night, but our diet high in fruit and vegetables, high in fibre, 20 minutes of moderate exercise and maintaining a healthy body weight has all been shown to reduce cancer risk in population studies by about 1/3. That's something that family can be doing, you can be doing. It's really very important. And I've put this not high dose vitamins here because prostate cancer has been one of those conditions recently where some big trials were done looking at high-dose vitamin supplementation, and for whatever reason, the results actually show that it could have been harmful. So high-dose selenium, for example, isn't recommended. Eating foods that contain large amounts of selenium is different because it may be something else in that food that's giving you the benefit. So as far as we can tell at the moment, we're not sophisticated enough to pull all the things we need out of broccoli, for example, and put it into a vitamin tablet. And for those of you that want to lose weight, I found this one on the internet just the other day and I thought it was rather amusing. How to burn 800 calories in just 30 minutes. So what is a genetic test? Assuming that you have one of those families and we've either found the loss of staining in the tumour or there's a 10% pre-test likelihood. And I must just say, though, most of the time we're going to get a lot more excited by somebody else in the family than the man with the prostate cancer, simply because we prefer to test the bowel cancers in Lynch syndrome and the breast or ovarian cancers in the BRCA1, BRCA2 situation. But that doesn't mean that you wouldn't get a test. In this case, it's a blood test. Blood contains DNA. We simply extract that. And at the moment, the way that we do it is gene by gene. So you just look for the one of the Lynch syndrome genes, for example, and you're looking for the copy from mum, the copy from dad, and you're just looking for one of these spelling mistakes or a piece missing. If we find that, then it gets very easy. We can do a predictive test. A predictive test is a yes-no answer. Either the mistake is there or it's not. Either you need the extra screening, possibly extra surgery, or you don't. And if you don't have it, then you can't pass it on to the next generation. So where did these mistakes come from? Well, most of these genes are actually very, very stable, and the mistakes were made generations, if not thousands of years ago. We know this from looking at what seems to be a de novo, a brand new mutation, and it happens much less than point something of a % in both the BRCA situation and in the Lynch syndrome situation. When a man makes sperm, he's got to divide all that genetic material in half. So if there is a mutation, there's a 50% chance of passing it on. In this case, the baby will inherit that mutation. It'll be present in every cell, and we can do a blood test to show that when that child is an adult. Or they haven't inherited it, they're not at risk. I mentioned that we use this 10% chance, and that's partly because these tests are expensive. It doesn't mean that you can't have one, but if you're going to spend $1,600 to $2,000 on a test, you'd want a reasonable chance of finding something at the end of it. Lynch syndrome's a bit cheaper in some ways because we only test for one gene, but if you're doing a test when you haven't got loss of staining, it's very unlikely that you're going to find something. The predictive testing, on the other hand, is much cheaper. I thought I'd spend a little bit of time talking about some of the current Australian research, given that I've said that we don't know a lot about what causes prostate cancer except ageing and those more random mistakes. The impact study was started looking at men who had a BRCA2 mutation, the one that increases the prostate cancer risk, and to look at what sort of screening is the way to go. And the idea was to try and to distinguish a way to differentiate between slow-growing prostate cancers and the rapid aggressive ones. Now, you guys probably all know there's a lot of controversy around this, and that's why there's ongoing research. And that's partly because PSA isn't always raised in a cancer, so it's not specific. It isn't always low. It remains low in some cancers. So it can go up when there's no cancer, and it can be low when there is cancer. So it's neither specific nor sensitive. The other thing is when the PSA is raised or normal, it's not telling us whether this is a very slow-growing cancer, never likely to cause trouble, or one of the aggressive ones that we really need to jump in and do something about. And biopsies do potentially cause harm and can even miss the cancer. Unlike a mammogram where we can get a good idea of where something might be, it's not the same when you go biopsying the prostate gland. And as I'm sure you can tell me, treatments can have side effects. So this was all the background to this study. This was why they decided to set out and do this. In terms of what they actually found, you'll have to watch this space. This slide which is about human breast tumours, is simply to show you that there is lots of research going on, trying to tease out not only what are the genetic mistakes in cancers that have occurred by random, but what are the risk factors and are they being inherited. This is just one of many large studies published in Nature over the last few years. And don't worry, we're not going to go into those ones. But to put it in another way, this is a graph showing a couple of the genes we've talked about, the BRCA1 and BRCA2. These are the Lynch syndrome genes and a few others. And I've used breast cancer partly because if I use this for prostate cancer, we'd really just have BRCA2 sitting there by itself. What this is saying to you is on, and I will turn around now, on the side closest to me, these are the very rare genes, and yet they cause a high increase in the risk of certain cancers. At the other end of the scale, you've got the very, very common, but don't cause a big change, genetic mutations. Using BRCA1 and BRCA2 as the example, they occur in about 1 in 1,000 people. Breast cancer in the population is about 10%. Prostate cancer, as we said, is about 6%. This is to age 65 is what we usually talk about. And yet if a woman has a mutation in the BRCA, as we discussed, there's about a 40 to 80% chance of breast cancer over her lifetime. Down the other end, these are these genome-wide association studies where you take lots of people and you try and look at everything and then try and tease out what's important. And there's thousands and thousands of these. We're going to take us quite a long time to sort out all the rubbish from the important stuff. But most of these, even the ones we know about, tend to increase risk just a little bit. So for example, the breast cancer might go from that 10% to 12%, prostate cancer from 6% to 6.5%. Not enough to really change any of the things that we're doing, or at least not at the moment. There are a couple in the middle there. These are the ones that we're probably going to find with prostate cancer are increasing our risk just a little bit. Lynch syndrome, it's debated. Is there really an increase in risk? Is there not? I think one of the things that we'll find is that as we treat people for the cancers that used to cause lots of trouble, we will see more of these other cancers coming through. So prostate cancer being so common, it's quite hard to tease out which are the ones that are being caused by a mistake in a gene passed down in the family and which are those that are just caused by living a long, healthy life. To determine these things, we work through what are called SNiPs and Chips. So what we start with is the DNA. We have to peel it apart and then read it base by base. Each one of those little prongs, little spokes, is a base. And you can have a mistake in any one of those. And there are 3 billion of them in our DNA. So to find a single nucleotide, one letter in that entire library with a mistake in it, is difficult. But by finding areas that seem to be associated with cancers, so finding the right part of the library at least, we can go through and try and work out, are there these little changes? There are some parts that have to be the right letter or will really, really bad things happen. These sorts of things, the SNPs, are common in the normal population. So you'll find a certain number of the people in this room might have the G and the others will have the A, and it probably means nothing. But you can then do studies looking at people who've had a cancer, and if you suddenly find that it's much more common than you would otherwise expect, maybe, just maybe, that could be something increasing prostate cancer risk. And this is the biggest area of ongoing research where you get all of those names on a paper. So they've got the practical consortium. It seems one of those things when you're doing research, you've got to come up with a really good acronym to get your research published. And they think that there are probably 40 loci, just means locations, little spots, clusters of places on the chromosomes that could be related to these families that seem to have more prostate cancer than we know should be occurring otherwise. And that's still only going to explain about 25% of the familial risk. So we've got 2 or 3% from BRCA and this other gene that they've only recently found, the HOXB13, which is very rare, 4 families only, if you think about how much prostate cancer is out there. So this is a pretty much a watch this space, but it is a very much the area that a lot of work's being done. So just to go through then, when should you see somebody such as myself? When should you go and talk to a familial cancer centre? Well, the easiest thing to say is if there are 3 relatives in 2 generations and one was diagnosed under 50, and that pretty much goes for any cancer. To be a bit more specific, if there's cancer at a young age, if there's a person who's had more than 1 cancer or multiple cancers within a family, like I said, sometimes there's special look that goes with these things. And the BRCA2 and BRCA1 mutations are much more common in the Ashkenazi Jewish populations, in the Jewish populations in general, but the Ashkenazi. In that population, it's about 1 in 50. So we will test a family member who's had a cancer and comes from that cultural background. So in summary, all cancer is genetic. It's caused by mistakes in genes. But most prostate cancer is not caused by an inherited gene that you inherited from your mum or from your dad and that you can potentially pass on to your kids. However, some are, and if your family history is consistent with them, it's very important to try and tease that out. As I mentioned, we can use some sneaky tests like the staining in Lynch syndrome, but a lot of the time it means sitting down and going through that family history. There is more information on the Sydney Cancer Genetics website. EVIQ is the national body that I work with where we put together guidelines on who gets a genetic test within the public system, and there's general screening advice available through some government websites. Thank you.
In the case of my wife, she had, I'm talking about tamoxifen now, she had breast cancer, and tamoxifen sort of kept it at bay for 5 years. Now, that's the background, but on the screen there you showed tamoxifen for 5 years from age 35. Is that just a short-term benefit too?
Very good question. In fact, what actually happened with that, it was because tamoxifen was used to treat women with breast cancer, and for some of those women, for many of those women actually, the breast cancer was gone and never came back, but they developed cancer in the other breast. And the number of cancers that women who weren't on the tamoxifen relative to those who were on the tamoxifen was different by about 30%. So it prevented about 1/3 of those cancers. Based on that, they then did big studies in women whose family histories put them at least a moderate to a high risk, and those women took tamoxifen for 5 years. And again, it showed that those women who'd never had a breast cancer, the ones on tamoxifen were about 1/3 less likely to get breast cancer than those that didn't take the tamoxifen. And yes, that benefit continues. The reason we say from age 35 is that's where the studies have started. But you could take it when you were 50 if you have a BRCA1 or BRCA2 mutation or a strong family history.
Well, if that's the case, that's a preventative course of action for any woman at 35 might as well have tamoxifen and there's some benefit. But is it covered by the public taxpayer?
Two questions, and both of them again good ones. The first question though, in order to take a medicine for 5 years, you'd want it to have absolutely no side effects at all in a healthy young woman if her risk was only average. So if your risk is only 10%, say 9% because the math's easier, you're going to reduce your risk down to 6%. That's not really a big enough benefit from a drug that can cause clots, strokes, uterine cancer, cataracts and some other things. But you're right, it is actually recommended for women who are at moderate as well as high risk, or at least to have that discussion. And the second one, is it covered? No, it isn't. It's not, and it's specifically not. There's very few medicines where they specifically tell you that you can't write a script. But on the other hand, it costs about $1 a tablet, so $30 a month.
Going back to that 3-2-1 rule that you set up there, I think this applies to my family. My father-in-law and my father had prostate cancer. I've had prostate cancer. My son is just coming up to age 40. His diet is terrible as far as fruit and veggies and all that sort of stuff. Pasta and meat, that's him. So it looks to me like he sort of fits well into that category there.
It's possible. The only thing that's not going to work there is, although you can be very close to your in-laws, you can't share their genes, unless, of course, there is consanguinity. So in your family, you've got your dad and yourself, and in a situation like breast cancer and prostate cancer, cancers that are very common, unless those cancers occurred at a young age, you would be thinking that's more likely average risk. So if somebody was under the age of 50, then that would be different. And particularly if you looked into the family and found bowel cancers or breast cancers, that's when you would be getting more concerned.
Yeah, well, my mum had bowel cancer.
Okay.
So
and again, so there what we would do again is look at how old she was. And when you have a cancer, they keep a little chunk of it for 15 years normally, and we can go back and stain that. If for any reason she was very young, 35 say, and wasn't around to have that test done, that's when we can do the test on the prostate cancer. But again, mum and dad, you're going to share their genes, but they're unlikely to have shared the same thing.
thank you.
And I suppose just on that, I should say, we know that you can't inherit two faulty copies of these genes, two mutations. The babies don't grow. So you can't have a BRCA1 from your mum and a BRCA2 mutation, a BRCA1 mutation from your mum and a BRCA1 mutation from your dad. The babies don't develop. And if it's two BRCA2 mutations, the babies get a thing called Fanconi anemia. So it's unlikely.
About prostate cancer risk, I guess we've all read that there is some variation with race, like people in East Asia get less and so forth. And also we may have heard a bit about testosterone levels as being relevant. So are they in turn related to genetics?
Not genetics so much, although there are conditions where things like Klinefelter syndrome, where there is no testosterone being produced. So there are situations where things have happened, or historically where the testicles might have been removed and therefore there was no testosterone produced. We know in those situations that the prostate growth slows, so you don't get benign prostatic hypertrophy, the same sort of thing that simply squeezes the urethra and makes voiding difficult, so not getting that flow. And those same sorts of changes can then result in less prostate cancer. Again, we know, like tamoxifen reducing breast cancer risk and removing the ovaries and tubes from a woman reducing her breast cancer risk. It's true that the same tablets that many of you may be on that limit the testosterone help starve existing prostate cancer. But I think you'd find it very difficult to sell a tablet to a young man that's going to remove his sex drive, make him impotent, on the off chance that he may avoid prostate cancer. But you are right, that would work. In terms of the race, there are racial differences in most of the genetic conditions that we know about. Some of those are very well known. You may know about things like thalassemia being more specific in areas where there is a lot of mosquitoes, so the warmer areas. But even things like light hair, blue eyes, those sorts of genetics. Really what it is, though, it's very difficult with something like prostate cancer to tease out exactly how much of it is related to diet and culture and things like that. But the studies are ongoing. I don't think there's any clear statement that we could make to say to one particular race, you'll never get prostate cancer, don't worry about it.
We've heard a lot of presentations about diet and exercise affecting people's PSA, etc., with prostate cancer. But the idea that certain diet and lifestyle can prevent cancer, how can that be determined? It's always got me wondering, because how do you determine that the people would or wouldn't have got it in the first place?
Very, very good question, and it's one of those things that's often levelled at population-based studies. So the first answer is, if you get enough people and you can divide them cleanly into those that did something and those that didn't, and try and show that those that didn't like say ate broccoli, that those that didn't eat broccoli didn't do so for a religious reason or a cultural reason or something else that might have meant that their genes were different, then you might be able to demonstrate that eating broccoli is beneficial. And that's pretty much how most of these studies were done. So the brassica family, broccoli, cabbage, Brussels sprouts and cauliflower have long been associated with an increased benefit, as in reduced cancer. There are some studies that say, well, maybe people who like the taste of it and therefore have some gene that lets them eat it is the same gene that's going to prevent their bowel cancer. So actually making that causative link is going to be very difficult. However, what they have also been able to do is take people who've had a cancer and then follow those who exercise and eat and fresh fruits and vegetables and so on. There's also a degree of biological plausibility, and that's why some of those vitamin and minerals dosage type studies were done, in that the idea that trying to think of the ones in particular. So if you're eating lots of fresh fruits and vegetables, you'll be getting vitamin A, vitamin C, vitamin E. Those ACE vitamins are antioxidants. Antioxidants help protect a cell from damage. Less damage, less genetic mistakes. So in that sense, it makes a lot of sort of scientific sense that that's what's going on. Trying to demonstrate that, it gets tricky. So you're right, we don't have all of the answers there. There is a very interesting study. I was at a conference on the weekend, and they were showing some data from a paper that I hadn't actually seen that was published in the end of 2012, where they took people and measured changes in their genes over a whole month and noticed how they changed based on whether they got an infection and what they ate and so on. That's very different. They're not the genes we've been talking about tonight, but it does seem to say that you can alter some of your inherited risk by diet, exercise, maintaining a healthy body weight. And on that, it's the healthy body weight. When you are overweight, your body's making more estrogen. And for women, that increases the risk of estrogen-sensitive cancers such as breast cancer and uterine cancer, but in men it has a similar sort of effect. It increases cancer risk.
Can I ask a second one about my nephew, which he always concerns me? His uncle on his mother's side died of prostate cancer. His father died of prostate cancer. And, of course, me on his father's side had prostate cancer. I think statistically with this guy, it's not if he's going to get it, it is when. Would you agree?
It could be. He may simply have fantastic genes. Everybody's living to be 100, and as a result, he'll have enough time to make those mistakes. It's also possible that there is something in the family, particularly if those cancers are occurring in the 50s, that is increasing his risk. At the moment, exactly what that is going to be very difficult to determine, unless, as I said, some of those other things that we've talked about. Really, whether he has a fault in a gene, a mutation, the things that he can be doing to reduce his risk are still there. And within the BRCA1 and BRCA2 population, we do have some of those studies coming through now, and within the Lynch syndrome population, that you can still reduce your risk of cancer, even if it's a very high risk, through diet, exercise and healthy body weight. Again, very easy to stand up here and say, but a very useful thing. So hard to say without knowing more about the family.
Thank you.
Is there any benefit of eating tomatoes?
Absolutely. Tomatoes contain lycopenes, and they've been studied for a long time. So we started off with data showing things like the Mediterranean diet, which tends to contain a lot of tomatoes, was helpful. And then they went on and actually did a study in prostate cancer where they fed rats lycopene and showed that the rats got less prostate cancer. I think we're not at the point of taking the lycopene out and sticking it in a tablet and making everybody have that. But again, if you're eating fresh fruits and vegetables and you're eating your tomatoes, great. If you don't like tomatoes, there'll be another brightly coloured fruit or vegetable that you can substitute. Eating tomato sauce doesn't count because there's hardly any tomatoes in most tomato sauce. But
To get the benefit from tomatoes, it's got to be cooked tomatoes, isn't it?
so again, that's a question that I get asked often, and it's the same with the sort of organic versus inorganic. Hey, anybody eating an inorganic tomato? Versus organic versus non-organic. There may be differences, but those differences are going to be small relative to not eating the tomato at all. So yes, but in effect, probably not that important. If you're avoiding eating tomatoes because you can't get the particular organic tomato that you want, you're probably missing out on a lot of the benefit.
So it's never too late to start a good diet.
Never too late, no. And I think that's actually what some of that research is now showing, is that although the genes that I've been speaking about have a mistake in them, a mutation that is going to be very difficult for us to find a way to fix, the switching on and off of other genes where you simply turn the gene off, it's a bit like in order to read along the gene and turn it on, the machinery has to attach, and so you can put a roadblock up so that machinery can't go. I'm mixing all my metaphors here, but if you stop that from happening, then that gene gets switched off. And if that gene happened to be an important spell checker gene, then you're going to increase your risk of changes. So I don't think it's ever too late. Certainly, again, we know from studies that have been done in people who've had cancer, things like exercise reduce cancer risk. And so begs the question, why is that? And some of the data seems to show that it's actually the way that these what are called epigenetic changes occur, and that's quite able to be changed.
A 30% reduction of cancer risk for people on a good diet. I presume that since childhood, I guess. So, I mean,
It's actually
figures for someone starting at age 60, say.
And again, you're right. I think part of it is those sorts of population studies are often been done in groups of people that you can get access to. So a lot of them are based on things like the big nurses studies that were done. So they were adults at the time, and they were followed through into their 50s and 60s and so on. So that was the time period that they were looking at. Asking somebody to go back and remember what they did is much more difficult and much more prone to inaccuracy. Some of the studies where they have tried to do that seem to have shown that the exercise that you do in your 20s probably is important, but whether it's simply that you just didn't start that process of building up mistakes, I don't know if you think about it as compound interest. If you start your saving program when you're younger, you'll simply have more when you're older. If you start later, you'll still get some, but you won't get quite as high. And it could very much be the same with the mutations. In terms of why it's not too late to start, is that until you've got a cancer, you don't have a cancer. So you might have those pre-changes, but prostate cancer is one of those things that we've known for a very long time, that it can grow very slowly, that there can be things that change very, very slowly over time. I don't know if anybody's familiar with the Detroit study. It used to be the gun capital of the US. I don't know if it still is. And they did an autopsy series where they simply started with everybody that had died of unnatural causes, but in this case it was a gunshot, and they looked at the prostate. So they started with people in their 20s and 30s and went through, and they could find prostate cancer in all of those people. So again, it's possible that in prostate cancer things can change slowly. It's also very possible that things change very rapidly, and trying to tease that out we're not good at. But certainly there doesn't seem to be any harm in eating a healthy diet, maintaining a healthy body weight, and doing your exercise.
You preach what you practice.
I do actually. I did a big walk on the weekend. I did. But I also practiced what my grandfather said, and that was moderation in everything, including moderation. So. Wise man.
Are there any more questions? Well, I think we'll close it there. But thank you very much for that. It was a very, very informative presentation. Certainly something we haven't had before. I don't think any of us have heard anything like that before. And some of us have been coming for many years, so it's great to get something new. But we really appreciate your time this evening. Thank you very much. Thank you.